And sorry for the cancellation last week due to power failure in my building. Today I have taken a little different topic, which is not clinical, because at least 5-6 doctors approached me that, it becomes difficult when we write medicine for depression, anxiety, etc. Because patients are not willing to go to consultants. There's still a stigma of psychiatry, and becomes difficult how to think of giving, how long to give, when to stop, when to change, all those things. So I thought, let me take this topic today. And going by the numbers, I think not many people are treating psychology in the clinic. So the entire psychopharmacology, all the drugs that work on our mind, work on the principle of neurotransmitters. What are neurotransmitters? They are chemical messengers in the body, in our body. The job is to transmit signals from nerve cells to target cells. They allow our brain cells to communicate with each other. So all the synapses that we know in our brain, all the cells sending messages, is all facilitated by neurotransmitters. And whenever there is deficiency of some, we get some problems, some psychological problems. They are endogenous. They are produced inside our body, especially in the neuron cells. They are not exogenous. So far, they have not been produced in the laboratory. If we have either weak or overactive neurotransmitters, they produce unnecessary chemical reaction that lead to mental health condition. So all our mental health is the result of chemicals which are neurotransmitters. Our happiness, our sadness, our dejection, our disappointment, everything is neurotransmitter. And what are the common neurotransmitters? Acetylcholine, dopamine. Dr. Shantilal Jain saying no sound. Are others able to hear me? Please give a message. Dr. Jain, check sound at your end because others are able to hear. Dopamine. Everybody has heard of dopamine. GABA, gamma aminobutyric acid. Glutamate. Histamine is also a neurotransmitter. What is most responsible for allergic reaction? Norepinephrine or noradrenaline. And lastly, last but not the least, serotonin. So psychotropic medications, all the medicines who work in mental health, act on one or the other neurotransmitter. They work by adjusting number of major chemicals or number of neurotransmitters in the brain. Increasing or decreasing certain neurotransmitters using medicines counters the effect of mental health conditions caused by deranged neurotransmitters. They can only treat mental health conditions, and they are most effective, not sometimes, most effective when combined with psychotherapy, either by us or by a counselor. Although we are not trained into proper psychotherapy, we the way we talk to our patients is actually a big psychotherapy. Please remember, they are not a cure. There is no cure. You can treat a patient, you can bring the patient into remission, you can observe the patient, you have to change the way of thinking, the way people keep busy, and then you have to wait till the next attack and treat it again. DSM-5 is the Bible of mental health disorders. And according to that, mental health disorders are divided into bipolar and related anxiety disorders. Then bipolar, where you have depression and mania at two ends of the spectrum. Depressive disorders, feeding and eating disorders, anorexia nervosa, bulimia nervosa. Obsessive compulsive disorders, OCDs, and related disorders, and certain personality disorders. This is as per DSM-5. As per ICD, there are several clauses. I'm not going to read everything, but this can be checked later on. Okay, one thing I forgot to tell you in the beginning. This episode on YouTube will be available forever, not for a short time. And those who want can request Preeti to get a PDF file of this document. Since it contains brand names, I cannot put it on Telegram. Those who want can write to Preeti and then they will get it in a PDF format. So these are the disorders which we don't have to worry about, the names and the classification. Let's look at the type of medication. Now, although when we write treatment for mental health disorders, we do not think of which neurotransmitter it may be affecting. But it's better if we remember what kind of drug that is. So there are 5 main types of psychotropic medication. Antidepressants. We know how common depression is. Anti-anxiety. We also know how common anxiety is. So much stress in life and the anxiety that it produces. At times, both depression and anxiety are situational and they do not need specific proper treatment. At times, depression is a primary depressive disease and anxiety is a all-pervading, without any reason anxiety, then it has to be treated. Stimulants, again, a class of medicine which for people who are more into depression. Antipsychotics. Antipsychotics are a very important drug, and although it's not much used by general practitioners, it's time that we learn to prescribe antipsychotics at the beginning at least. Because, many patients we will get who due to extreme stress will go into acute psychosis, which is not a proper mental disorder, mental health disorder. It's not permanent. I'll give an example. It happened about 22 years back or 23 years back. A patient of mine, a very wealthy person, his son got married to a girl from a much lower background financially. Looking at the dhamal that happened in this wedding, The girl at the stage of the reception went into an acute psychotic episode. The reception had to be cancelled. The boy's family wanted to send the girl back. I told them that this is the result of her not being able to adjust to all this. We involved a psychiatrist who agreed. He said it's an acute psychotic episode. She was treated for about 6 weeks. Within 24 hours, she came around. And it's been now 20 years, 22 years that she's normal. She's not had a relapse. So I think I will cover antipsychotics next week. If you are willing, then, we have to identify at least antipsychotics. And secondly, most of the schizophrenia patients present in early 20s. And as a family physician, we have to identify the subtle signs before they become outright psychotics. And mood stabilizers. Then we have to remember one thing, that although these drugs, we said neurotransmitters for messages in the brain. Neurotransmitters up and down cause mental disease. But understand one thing, the drugs that we give for mental health affect the whole body. Why I'm saying that specifically? Because the side effects will not only be in the psyche or the mental status, it will be all over the body. Whichever drug you use, we decide, there are 5 different types of painkillers. We decide which one we want to use for a particular patient, for mild, moderate, severe pain. And then we study that drug so that we know everything about that drug. So you decide which drug you are going to use. Identify 5 of antidepressants, 5 of anti-anxiety, 5 of antipsychotics. And then you can actually do very good practice. Remember the common and dangerous side effects. These side effects will have to be correlated with patient's age and patient's comorbidities. And what, if any, investigations have to be done periodically to make sure that there is no organ damage. And side effects indicate that the drug is working. Most of us, if the patient complains too much, we tend to change the drug or stop the drug. Please do not. That is an indication that the drug is having effect. You will only have adverse effect if there is a therapeutic effect. Coming to the basic class of antidepressants, because depression is very common. I thought I'll cover depression as a separate topic today. So we have selective serotonin reuptake inhibitors called SSRIs, which increase the amount of serotonin in our brain. That means serotonin deficiency leads to depression. And then when you give a chemical, a drug that prevents reuptake, the serotonin levels will increase and the patient's symptoms will be better. Serotonin is a very powerful neurotransmitter that regulates the mood, bowel movements. Bowel movements, we know that most of the antidepressants will give constipation as a side effect. It regulates sleep my patient will sleep better if not sleeping well earlier, or if sleeping well earlier, then maybe little more drowsy. So I have to adjust the timing of the medication. It may affect blood clotting. So I will be careful if my patient is taking clopidogrel or any other anticoagulants and much more. So you have to study the drug, study the side effects of the drug. Then another group is SNRI, selective norepinephrine reuptake inhibitors. Gradually increase the amount of norepinephrine in the brain. Norepinephrine or noradrenaline makes one feel awake and alert. Noradrenaline makes us feel alert. So there are SNRIs which are also used for depression. Then there's a drug called bupropion. This drug, in addition to depression, we may not use much in depression, but it is seasonal affective disorder. Some people feel depressed only in winter. Or, as they say that days are smaller. Sunset is earlier, sunrise is late. Some people feel depressed that time. Bupropion helps there, and it helps quitting smoking. So if I have a patient who says, Doc, I want to give up smoking, but I cannot, I prefer using bupropion as compared to nicotine patches and all. So whatever frequency the patient has, I divided it by 8. And each week, 8-week schedule, I tell him or her to reduce the frequency weekly. And I put them on bupropion for 8 weeks. And they very comfortably are able to stop smoking. If you plan to use it for quitting smoking, then make sure the patient is not drinking alcohol. If the patient is an alcohol drinker as well as a smoker, we know that we never tell people quit drinking unless they have cirrhosis, but we say alcohol in moderation. This, we will tell them first stop alcohol, then I will give you medicine to quit smoking. What are the common side effects of antidepressants? They cause drowsiness. So how we manage? We give the last dose of the evening. We don't tell them take at sleeping time. We give it 8, 8:30 or 9. 9 is the latest. Then the drowsiness in the morning is much less. Insomnia. They may lead to insomnia also. So it is, paradoxical. The same drug may give side effect as insomnia or excessive sleepiness. Constipation, as I said before, commonest side effect of antidepressant is constipation. Weight gain. Somewhere people start gaining weight. I cannot explain the physiology for that, but then, yes, they gain weight. And also, I must narrate a case here. My first cousin, this was way back when I had just started practice. He was in Delhi. He is in Delhi, still alive. And, over a month, he lost 25 kilos of weight. He was overweight. He was about 100. Over 1 month, 25 kilos weight loss. And we all were worried of cancer. We called him here because in those days, 40 years back, Delhi didn't have many hospitals. He was investigated thoroughly, no disease. Then my classmate, one Dr. Iyer, he spoke to him and we realized he was majorly depressed. And the cause of depression was only one, that his childhood friend, his best friend, had fought with him and stopped speaking to him. So this cousin of mine, after being treated for depression, he actually started gaining weight and gained almost 10 of those kilos he had lost in 4 months' time. It causes erectile dysfunction. Although physiology of erection has a lot of aspects, including vascular, it's ultimately the state of mind or the emotions. So then depression itself may cause erectile dysfunction. The drugs may also cause erectile dysfunction. They may get tremors and they may get dry mouth. Now, some will get more, some will get less. So the drug that you want to use, you have to be very careful in understanding the whole thing. The best way what I do is, if I want to use a particular brand, I approach my nearby chemist and I get the literature inside, or I look up the internet and I read the whole product insert that has been given. That gives me enough information. So let's look at the first class, SSRI. Selectively inhibit the reuptake of serotonin. Citalopram, we consider as anti-anxiety, actually SSRI, falls in the category of antidepressants. There are 3 brand names: Citalo, Citara, and Citadep. Escitalopram, Deplam, S, and SDEP. Fluoxetine, one brand name is Fludac. Half-life of 4 to 6 days. Thus takes several weeks to get therapeutic level. So if you advise somebody fluoxetine, it's a drug I use very often. My first follow-up is after 1.5 months, not in 10 days, because I will not get anything. That is why if it is suddenly withdrawn, there are no symptoms because the half-life is very long. The normal dose is 20 milligram. It's more activating. That's why the early morning dose 8 a.m. So I use fluoxetine and I start, like the prescription says 8 a.m. and most people are empty stomach at 8 a.m. It's okay. Another side effect of this, which we use to our benefit, is it causes loss of appetite. So I will select it for a patient who's generally overweight. And then if patient loses some weight, it is going to be beneficial. Fludac, Cadila Pharma, Flunil, Intas Pharma, Prodep, Sun Pharma. 3 brands. We start with 20. When the patient is better, we reduce to 10 and then we stop. Then we have another SSRI, same thing. Fluoxamine. 2 brand names, Fluoxin and River Life. I have never used it because I am very comfortable for last 10-15 years with fluoxetine only. Paroxetine, Panic CR 12.5-25 or Pari CR 12.5-25. This is another good antidepressant. Sertraline, Daxid or Serdep. You understand one thing, if you are using SSRIs, you use only one, don't use multiple molecules. And Vilazodone, Vilano 20, Vilamid 20. So where are they used? Indications are generalized anxiety disorder also. SSRI is used. Our citalopram and escitalopram. PTSD, post-traumatic stress disorder. Nowadays, everybody is stressed. But PTSD, we saw a lot in Bombay in early 90s, when there was riots and people actually saw people running with swords on the roads and several doctors were kidnapped. So people who had seen that kind of trauma generally went into PTSD. It is common in people who have experienced a near-death situation. SSRIs work wonders. OCDs, SSRIs work very well. Treatment of OCD is generally SSRIs only. Depressive illness, whether it is a situational depression or is it a primary involutional depression. Panic disorder. Citalopram, escitalopram work very well in panic disorders. Social anxiety disorder. There are children, of course, we don't give it to children, but adults who don't like mixing with people, who get put away by a crowd, we can treat them like that. Bulimia nervosa. Here, they eat a lot. And then they are scared of body weight gain, so they actually go and vomit. These patients benefit very well with fluoxetine. And at times, menopausal symptoms get helped with fluoxetine, or other drug that works is amitriptyline or tryptomer. Side effects of SSRI specifically: GI disturbances, bloating and constipation, sexual dysfunction, erectile dysfunction, except vilazodone does not give. So if you give somebody Flodex and the patient complains of erectile dysfunction, you can shift to vilazodone. Insomnia, except paroxetine is sedating. So, when I said study a drug, study your patient. If your patient says, no, I am not getting sleep, doctor, then I will give him paroxetine because it is sedating. It will do my job of insomnia also. But if the patient says, I am always sleepy, I will give fluoxetine. So that is why I must again emphasize, nobody can help you create a prescription, but your own study of the drug and the study of the patient. Anxiety may increase, depression may go down, anxiety may increase. Patients may get irritable. All these things will be reported by the family. Seizures, although very rare, but there is a possibility. And SSRIs have a plus point. There's a very low risk of cardiotoxicity. So you can give comfortably to a patient who's a heart patient. Antimuscarinic side effects: dry mouth, urinary retention. So I will be careful in giving to a patient who has a prostate enlargement. Discontinuation syndrome, if it is stopped suddenly, symptoms may include dizziness, headache, nervousness, nausea, and insomnia. These symptoms will not be present in fluoxetine because of the half-life of 4 to 6 days. This is for other SSRIs. Weight gain except fluoxetine, which causes weight loss. Then we have second class, SNRI, serotonin norepinephrine reuptake inhibitor. They inhibit both serotonin as well as norepinephrine reuptake. Molecules are venlafaxine, brand name Dalium or Flavix, desvenlafaxine, D-Veniz or Vens OD, duloxetine, Diloc or Dulane. Now we also know duloxetine also works for diabetic neuropathy. Milnacipram, Milnes or Milza, and levomilnacipram, not yet in India yet. The commonest SNRI we use is duloxetine or venlafaxine. Indications again, major depression, generalized anxiety disorder, social anxiety disorder, fear of people around you, menopausal symptoms, fibromyalgia. Fibromyalgia is helped by SNRI. PTSD again, post-traumatic stress disorder, and stress urinary incontinence, duloxetine. Women with a weak pelvic floor muscle. You know, women who come to you very embarrassed, their doctor, if this cough is not going, and when the cough comes, I leak out. They're working women, or even if they're at housewives, it's very embarrassing. So for a short time, even though there are no depression symptoms, you can give duloxetine till you control the cough. And then you have to explain to them Kegel exercises so that their pelvic floor muscles are strengthened. And diabetic neuropathy, again, I said duloxetine. Side effects are sexual dysfunction, nausea, dizziness, hypertension. So again, monitoring of blood pressure is always required because it is SNRI, noradrenaline uptake inhibitor. That means noradrenaline levels go up. And noradrenaline is one of the drugs we give in shock to maintain blood pressure to normal. That is why these people may get hypertension. And if they get hypertension, you would rather change from SNRI to SSRI rather than continuing SNRI and giving antihypertensives. QT prolongation. So if you are giving SNRI, you must do a ECG at the initiation of treatment and every 3 to 6 months based on what was QT interval. Those of you who do not know ECG will say, what happens if QT interval goes up? A QT interval above 0.44 is a risk factor for malignant arrhythmias and sudden death. Then they get dyslipidemia with desvenlafaxine, suicidal thoughts, constipation. So, you know, all this tells you that if you're treating mental health, every follow-up should be timed at least 15 minutes with the patient. Don't take it in between your busy practice. Call them before or after the clinic. Headache. Then we have third group called tricyclic antidepressant. These were the first group of antidepressants. They block reuptake transmitters of both norepinephrine and serotonin, but have also anticholinergic, antiadrenergic, and antihistaminic activity. Their side effects are much more than SSRIs. Amitriptyline, tryptomer or amitrin in 10 milligram, it is best for neuropathic pain, migraine prophylaxis, and even for nocturnal enuresis in children. For depression, we go to 25 milligram. Imipramine, Depsonil or Antidep, 25 and 50 milligram. Depressive illness, nocturnal enuresis. And clopyramine, anafranil or clofranil depressive illness and obsessional or phobia disorders. Doxepin is another type of tricyclic antidepressant, brand name Doxitar or Doxin. Triimipramine, Sermontil, nowadays not used much. Nortriptyline, Primox, Enzival. Actually, tricyclic are used more for non-depression conditions because the side effects are very common and very many. Desipramine, again a molecule of the set. Norpramine, not yet in India. Amoxapine, Demolox, Depilox. So, I would recommend that you study more of SSRIs and somewhat of SNRIs. Tricyclic, you keep 10 milligram for neuropathic pain, fibromyalgia, and even nocturnal enuresis. You can give a 10 milligram tablet to even an 8-year-old child, and it is safe. Side effects. Antihistaminic side effects are sedation and weight gain. Anticholinergic side effects are dry mouth, dry eyes, constipation, memory deficit, and potentially delirium. Many a patient we have started on imipramine, but we were forced to stop because patients were so much complaining of dry mouth. See, we get dry mouth for 5 minutes, we get disturbed. Imagine sipping water every 5 minutes and still dry mouth, then people don't want to take that medicine. Anti-adrenergic, orthostatic hypotension, and sexual dysfunction. So if you see, the side effects are much more than what we had seen with SSRIs and SNRIs. QT prolongation, seizures. Now, see, you may have a ECG machine, but patient then starts suspecting, are we doing rational practice or not? I have come for depression, doctor is giving medicine, then he's saying for that I must do ECG before. Become suspicious. And suicidal thoughts. Then there are, we already mentioned bupropion, atypical antidepressants, indications, mechanism, and side effects. So I will not spend time in each one because I'll send you this PDF if you want, or it will be on YouTube. But if you see, bupropion to aid smoking cessation is the main thing. So if you may not remember bupropion for anything else, remember for smoking cessation. Mirtazapine is very good for major depression with insomnia. Trazodone, nefazodone, vortioxetine, we don't use now, but it is there in case in future they become important drugs. You will be able to save this data with you. Then we come to mood stabilizers. It's a category of mental health treatment, psychotropics. The commonest mood stabilizer is lithium. Lithium carbonate, if you are treating a bipolar, a patient who gets into depression or in mania, then once the patient is controlled, you give lithium both for treatment and prophylaxis of bipolar disorders. If a patient is getting recurrent depression, now, all right, again depression, then you consider lithium. Other mood stabilizers, if you see, they are actually anticonvulsants, but they are used also for depression. Sodium valproate, carbamazepine, Tegretol. Tegretol is also used for neuralgias, and antipsychotics also are used. Lithium, bipolar mood disorders. Prophylactic for both depression and manic attacks. When you give lithium, every 2 to 3 months, check for creatinine and SGPT. Positive response more predictable of lithium if the frequency of episodes is low and there's a blood relative with a diagnosis of mania. See, many patients of depression don't present as bipolar to begin with. They may have depression for 5-10 years, then suddenly they will get mania. So if there's a blood relative for mania, then you can start lithium. Less effective if episodes are more than 4 a year. Works either alone or with tricyclic antidepressants in acute phase. Useful of recurrent unipolar depression, acute depression in a patient with bipolar disorder, almost entirely excreted by kidneys, hence periodic serum creatinine. SSRIs are most commonly prescribed to treat depression. So identify SSRIs. I said 5 SSRIs and then study them and then decide which one you will use. They're often used as first-line pharmacotherapy for depression and numerous other psychiatric things like anxiety, panic disorders, etc. Because they're safe, they're effective, and they're well tolerated. I have patients on fluoxetine for almost 8 months and no side effects. Antidepressants are used in many other illnesses, as we saw, more in anxiety and other non-mental health conditions. Remember this, full clinical response in 6 to 8 weeks. So do not think of changing medicine in 10 days, 15 days, 3 weeks. In major depression, and up to 6 to 12 weeks in OCD. You know, patients, when they decide that they will take medication, they're always in a hurry for results, but before you start treatment, you must caution. So if for today's talk, you only remember this much, no? Full clinical response in 6 to 8 weeks. Like when I give a topical application for fungal infection of the nail, I tell patient for 2 months, don't expect any improvement. Don't think medicine is not working. Examples the commonly used are fluoxetine and paroxetine, fluoxamine and sertraline, and imipramine. For how long to give? Very important question. It's generally recommended to keep medication on for 6 to 9 months before considering tapering off or stopping. If there have been 3 or more recurrences of depression, make that 6 to 9 months at least 2 years. Because, you know, in depression, patient may suffer. The family suffers more. So if you have got result, don't be in a hurry to stop. And if the patient also has anxiety, or can I combine antidepressant and anti-anxiety? Yes, very often. When treating anxiety disorders, antidepressants, particularly the SSRIs and some SNRIs, have been shown to be effective. Especially I told you citalopram, escitalopram, wonderful anti-anxiety drugs in addition to depression. So anxiety and depression occur hand in hand. Most often, both symptoms and therapies go hand in hand. I'll stop here today. Next week, I'll take antipsychotics, and then we will see what we want. Dr. Ashok Mishra has asked, chlordiazepoxide can also be given. Dr. Ashok Mishra, chlordiazepoxide is a wonderful drug, but unfortunately, it's not available very freely nowadays. And I will give one indication where you can use this. If you get in the market, any patient is giving up alcohol, they need support. That is the time you give chlordiazepoxide 10 milligram tablet 333, and you will still have to give a sleeping tablet. Then this patient will not have any withdrawal symptoms. There is another condition of chlordiazepoxide being used. 5 milligram of chlordiazepoxide with clinidium bromide is used for IBS. Wonderful results. But then again, availability is not very easy. Dr. Ufri Zirani, how does depsonil works in nocturnal enuresis? I'm sorry, the detailed physiology I cannot give you, but it works wonders. SB is asking, although it's not a webinar on COVID, but still, can you comment on recent news about COVID new variant? I have not seen any cases, but yes, we have to be alert. Like I have just ordered 1,000 masks for my clinic because we were using earlier one for every patient who comes in. According to me, the problem will be this. Today, if you tell a patient where you suspect COVID to do a test, people refuse. So we have to be alert because it won't take time from this becoming a true pandemic again. But as of now, I think we can only say that we have to be alert and nothing more. Because see, even previous last 6 months, all COVID positive, we had not even given zinc, vitamin C, nothing. Just monitor oxygen temperature, paracetamol SOS, hydration, and good nutrition. So I think COVID is here to stay. Dr. Kashyap Dakshin is asking any word of caution for usage of anti-anxiety antidepressant with regards to risk of Alzheimer. Dr. Kashyap, Alzheimer is not a sequel of depression, although it may coexist. But then so far, risk of SSRIs or SNRIs have not been shown to have risk of Alzheimer's. I will still do some research. It's a good question. So next time I'll update that. Should we advise patients to cancel domestic tourism plans? I would say no. Because see, let's be careful. Let's not be in panic mode. Dr. Ufri Zirani, does hypoglycemia affect depression, please? No, at least not in my knowledge, because both are different conditions. We'll stop here. And next week will be melatonin and fluoxetine. Yes, you can give together also. Those who are interested, next week, little bit on anti-anxiety and more on antipsychotics. Take care.